thank you to all presenters. We have 4 of them staying on for the remainder of this meeting, so we can have a panel discussion here with any questions from the audience as well as any observations. Of course, with this important topic, there's never enough time to cover everything we would like to cover. What we've heard today is a lot of information about how complex some of the diseases that we work with are. In rheumatic conditions, really we see a disproportionate impact to women, children, and underserved communities and populations, which makes matters even more complicated. We also have an aging workforce, which is not even distributed across the country. You heard a few common themes about the importance of inclusion of patients in the decision-making and enabling some of the more informed conversations without implicit bias. So there is so much that needs to be addressed, and that's why at the Arthritis Foundation we thought it was very important to start with giving out the research funding for both research initiatives and curriculum development, but have now transitioned to funding larger and multi-institutional collaborations because there's so much need in this space. So with that, I will just start with one question for everybody, which is, I mentioned that and I know many of you already addressed some of that, is that where if you had an opportunity to scale this work further, what do you think are some lower hanging fruit or more feasible things that could be done with your program in order to make it multi-institutional or take it across states, as Candace was mentioning, or expand it in a way that could have a really positive impact on diversity, equity, and inclusion, as well as health outcomes for patients? And I guess we can start in reverse order and go with Dr. Vora first.
Sure, thank you. Well, specifically highlighting my project, I would love to leverage technology and artificial intelligence and informatics. You know, because we're using a triage form and highlighting specific characteristics that will help providers not only to educate themselves on what is important, you know, when as a rheumatologist, what we look for that could really lead to a patient having a rheumatic diagnosis. I would love to leverage technology and love to leverage AI. And how do we, you know, bring that together along with clinical informatics so that we don't have to have manual evaluation, but we can have this just kind of in real time in a provider's office where the data is entered, it's evaluated, and it gets spit out that you have a blank, yes, you should refer percentage-wise to a rheumatologist, so that it really helps to streamline the process and improve efficiency. So we can make sure that our schedules are filled with patients that really need to be seen. And we are, because of the workforce issue, utilizing our time in the most efficient way.
Great, thank you, Dr. Vora. So I guess I'll go to Dr. Lew next because I think that we're gonna see a connection here. So yeah, please go ahead.
Yeah, I think for our project, what we would like to do is expand out. Right now, as I mentioned, we're screening in the lupus clinic and in a couple of general rheumatology clinics. But if we could expand this further, I think that would be ideal. We have this proof of concept that our screening tool works. So now we need to figure out how to ensure that other people are using it. The challenge, though, I think that we'll hit is you know, not just screening, but also addressing the needs that have been identified. So the other element that I think needs to come with the expanding and, you know, making this more widespread is ensuring that we have social workers, patient navigators, community health workers available to help address identified social needs so that we really can, you know, refer patients to resources as needed.
I think
my project was a little different in education.
Yeah.
I think as far as scalability, the main limitation is availability of instruction. So this was relatively time intensive as far as giving one-on-one feedback on scanning, which is, I think, what's needed in order to help someone improve. Parts of it are automated as far as going through, say, the x-rays and having an automated system tell you what the correct answers are. But that was, while it was important, I think where the participants got the most interest was the direct feedback and direct interaction. So to scale it, we'd have to have a number of instructors that could go through this same process. And then we could expand it to having potentially dozens of people participate simultaneously. Of course, that would need to be funded, which is, of course, a separate issue.
Yeah, thank you. And I know that there have been some models of training the trainers, so the trainers can then train more, but even that requires both, obviously, funding initially and then time, which is definitely something that came up in every single one of the presentations. Okay, great, thank you. So Doctors Case and Feldman, I know that you had established a very successful program for curriculum development and trying to include health equity issues in some of the teaching of residents. Do you want to comment some about the scalability? You already started talking about some of the challenges expanding beyond the state of Massachusetts, but how that might be used on a larger scale, especially to help institutions that have more limited resources as you're doing now for some of the other institutions within Massachusetts.
Yeah, so I think, so I think there are different components of the program that could be scaled in different ways. I think for the, one issue is around rotating residents from outside of Massachusetts. I think one thing that has been helpful that, we intend to circle back about in a little bit is, one of the participants in our project is Alden Landry, who runs initiatives like this out of Harvard Medical School. And one of the things that he has been trying to establish across the entire medical school is a rotating residency program where the credentialing and all of these aspects are sort of managed centrally, which I think would be great and would really streamline the process and allow us to expand without the tremendous administrative burden of, each division sort of doing this separately. I think from the health equity standpoint, most of the things that we've developed, one of the things that we're doing is anytime we invite a health equity related speaker, we're asking permission to record the talk, and we are asking them for 1 or 2 articles that they think are pertinent. And then we basically are keeping a shared Dropbox of almost like a library of these resources, which is certainly scalable and nice because it could also be asynchronous. So I think that piece is really scalable. And I think that, as we think about how this could be across, other places and programs, the material certainly could reach people of any level of their training. And that's sort of the goal of it as well. People who don't know anything about health equity, people who are experts in health equity. I think that the goal really is to make sure that this permeates our field and isn't just for people who are looking at, considering a career in rheumatology, but really shaping the kind of culture of those of us who are already in rheumatology to recognize the importance of this. So I think that this curriculum could be, incorporated into, faculty level, trainings, as well as, rotating residents and such pretty easily, with people picking and choosing the pieces that they have time for, which was the goal for us.
Okay, great, thank you. So I know we have a few minutes left and I haven't seen any questions from the audience yet. So I'm going to end with a question unless we see another question from the audience, which is to ask each of one of you if you have a call to action or something that you would like to share with the audience in terms of the important issues or things that we can do as a community. It doesn't have to be addressed toward the Arthritis Foundation only. It could be addressed to AMC or ACR or any other organizations that are involved in DEI issues in rheumatology and in curriculum development. I'm going to go in turn and see if you wanted to share something as last thought or call to action as we kind of wrap up and prepare to adjourn. And why don't I start with Dr. Vora again?
So that's really a lovely question. I don't know, it comes from many places, but I really just think for me and my team and my specialty center wide, it's not being afraid to ask people, what are their issues? Why can't they come to an appointment? What's the no-show issue? What are the barriers? And don't be afraid to ask. I feel like everyone is human. At least this is, my experience. And sometimes we just assume, and that's the worst, right? So if we want everybody to have the best care and the best outcome, we need to be brave and we need to ask. And we need to say, how can we help you? And I think it's by the work that all these folks are doing, by looking at where the barriers are, where do we strategically focus our efforts if we only have so much money and time, based on the work of where are the biggest barriers. But then I think just at a very simple level, when you're with your patients and you notice that there is something, to include everybody in the conversation, to make sure you're meeting them where they are, I think you need to ask and you need to be receptive. At the end of the day, everyone is vulnerable. And I think, if you provide an area of safety, I think everybody will be generous and will open up and you will get the care that you want to give and the care that the patient needs to receive.
Thank you so much, Dr. Vora. Okay, Dr. Lew.
Yeah, I think what I was thinking is actually pretty similar. One of the elements of our project that we think is a next step is making sure that we have educational materials or some kind of messaging that we can provide to our clinicians to ensure that they know how to have conversations surrounding social determinants of health as part of the clinical encounter. Because even our clinic champions that are really invested in this idea still sometimes have challenges incorporating that as part of their appointment and their visit with their patients. So I think that one of the challenges that we need is to develop kind of educational programs or awareness programs to ensure that the rheumatology providers know how to incorporate this into their course of clinical care.
Wonderful. Thank you. Dr. Kissin.
I guess it'd be to have broader targeting of the medical students for rheumatology in general, and especially the underrepresented minorities in medical school. We had, like I said, only one applicant out of medical school for this program, which was a surprise to me. And I think that's because they're not really thinking that far ahead yet. So a call to action would be to advertise how interesting our field is and the fact that we can take more people.
Wonderful. Thank you. All right, Dr. Case and Dr. Feldman.
So we, Candace and I have been texting about this. I think that if we could call to action, it would be around both workforce issues, but also equity interventions and trying to get more cross-institution collaboration. I think that I was really inspired by talking with these students who have been rotating with us, that their interest is really there, and it was more that they didn't have exposure to rheumatology before, and that there's a lot of administrative barriers to being able to do rotations like this. And so anything we can do to make that easier for them, I think would be wonderful.
Great, thank you. And I can end with my own, which is also was mentioned by each one of you, the importance of funding for this type of work, because we can't assume that it will just happen in the background with everything else that is happening. It's very important to do this in a very consistent and intentional way. And I'm very proud of the work that the workforce development and DEI working groups have done with the Arthritis Foundation. We're actually submitting a manuscript with some recommendations resulting from the work, and hopefully more of that will happen as we share with each other the lessons learned and create an even broader and more inclusive community of people who are really involved in this work. And so with that, I would like to thank everyone for their participation.